Shepherd University. Got it. And I run the Listen, Learn, Engage initiative here on campus for the students. The mission of the Listen, Learn, Engage initiative is to inspire students across different disciplines to participate in constructive and skillful leadership and civic engagement that's tied to their field of study. So one of our goals for this semester has been to provide opportunities for our future frontline workers like Shepherd's nursing and social work and education students to be able to better understand the diverse experiences of the pandemic, as well as how best to support those who have been most adversely impacted by the pandemic. And a big part of that is understanding trauma and doing the DEI work. So with that said, I'm so grateful to Dr. Howard Bostic and our wonderful speakers tonight for sharing their insights into how we can use social and emotional intelligence to create safe spaces within our social services. Thank you.
All right. So it's my responsibility right now to kick up the energy up in here because we are going to have a wonderful evening and conversation. So I'm going to slowly migrate this team by using the pen tool. My name is Dr. Shaquita Howard Bostic, and I am the associate professor. I'm an associate professor of criminology and sociology, and I'm also the associate vice president for diversity, equity, and inclusivity at Shepherd University. So I've been honored to partner with Stubblefield Institution and a number of organizations for this week-long training. And what our goal is to have everybody to step back for a moment and to, number one, fill your cup, because some of our cups are empty. Fill your cup. So we're going to do that. We did that on Thursday with a meditation session, which I'm going to make sure that you all get the video link to that. So I'll make sure we do that. Some housekeeping. I need everyone to put your first and last name and email into the chat for me. So put your first and last name and email into the chat. If you don't want any other people to see it, you can put private. You can put just to me, your first and last name and email, because I want to be able to get you information. But okay, so anyway, so we're going to fill our cups some, and we're going to fill our cups by, learning to meditate and focus and understand what we need to know about ourselves so that we can stay healthy and so that we can stay focused and ready to engage. That was the first step in this process. And the second step is understanding like hardship and challenges that have existed in the pandemic that turn into some form of trauma. And it could be trauma that other individuals are experiencing, but it can also be the trauma that you're experiencing personally. So we want to kind of understand what that looks like and different ways to respond to it. And note when we say social services or social sciences or whatever field you happen to be in, all of this is applicable, note. So if you are working in a particular field, please understand that something that I go through as a professor of sociology may be applicable to something that Rachel Tizer or Elizabeth Mobley or, all of our speakers and the different people who interact today. You can look at and hear those experiences and try to place them in the context that makes the most sense for you. So don't think that just because we're talking about social services that the experiences can't make sense. I need you to open your minds and open your hearts and think critically about how you can use this information to help you or to help someone who is very important to you. So with that being said, I'm going to slowly migrate our guests in. I'm going to start off here with the first person that I see to pin, who is Elizabeth Mobley. So Elizabeth Mobley, she earned an MAT in special education. She is currently the Parent Engagement Resource Center Coordinator for Berkeley County Schools in the Office of Special Education. Who do I see in my magic mirror? You'll remember that. If you don't remember that, that's okay. I see Amy Hampton. Amy Hampton earned a master's in social work from the University of Maryland, a Bachelor of Arts in Psychology, and an AAS in Criminal Justice from Fairmont State College. And she is an assistant professor of social work at Shepherd University.
What?
Who do I have? Haven.
Girl.
All right. So Haven Silvio Ingling. Am I saying it right? Help me out.
Silvio Eagling. Yeah, you were right.
Okay, I got it. I'll get it together. All right. Earned a BSN from Shepherd University in 2020 and is currently employed as an RN in Inova Fairfax Medical Campus, working on their level 4 in NICU. Am I saying it right?
NICU, yeah, perfect.
NICU. I learned that. And oh my goodness, I did this on purpose. And then Rachel Tizer she has a BSN and she's an RN and she is a graduate of Shepherd University's nursing program 2018. So she's employed as a registered nurse supervisor at Stone Rise Healthcare in Martinsburg, West Virginia. So I'm going to have the speakers to unmute, and I'm going to have everybody else to mute if you can. Annie Lewin and Cindy Powers are going to help me to mute people who are unmuted. So I want everybody to understand that if you happen to not be muted, somebody probably will, but we're not doing it to be mean. We're doing it to make sure that we can have a crisp video. So if someone mutes you, please don't be offended. Just be happy that we're in this together. All right. So with that being said, hey, everybody.
Hey.
Hello.
All right. What we want to do is we want to start our conversation by just really centering on what you see as being some core challenges that exist during the pandemic. And what we're talking about are challenges that are specific to at-risk populations. So we want to focus our attention first to at-risk populations. And then from there, we can just talk about everybody. So we're going to start right in the center there and then move out from there. So I guess we could start off with just maybe one challenge from each of you, and then we'll kind of move from there. So whoever wants to begin that conversation, that's perfectly okay.
Well, I don't mind if that's okay.
Okay.
So speaking from the educator's perspective, specifically special education, we're really seeing that there's a lack of access and a loss of structure in instruction, particularly as it pertains to our students with exceptionalities. So our students with medical complexities, those with disabilities, whether they're ADHD, autistic, various identifiers like that, school is extremely important for them. So that lack of access to the diversification and differentiation in their education programs and the loss of structure, because much of the time their educators are their constant force, right? 5 days a week. And the pandemic threw one of the worst monkey wrenches, for lack of a better phrase, in that opportunity. And the lack of access extends over, because this is West Virginia, right? So much of our population, if they're not transplants here, they're in the poverty range financially. So although they had a lot of programs, we're providing iPads and or Chromebooks, you still are seeing that students don't have easy access to internet or easy assistance with navigating these devices. So it's really important that we support these families, especially if you have lower income and children with disabilities. A lot of their parents also may have literacy challenges. And I don't just mean as it pertains to reading, right? Because when we say literacy, we think, okay, they don't know how to read. No, beyond that, like technological literacy. So we're equipping these students with devices, and yet they don't even have the support at home to navigate these devices and these programs. So that impacts and compounds the loss of structure in the instruction. So, yes.
Thank you so much. So this is what I do. You all know that. I'm gonna, after somebody says something, I'm gonna go back and try to highlight a couple key points so that we can piggyback off of that. And so what I hear Elizabeth saying is that there are multiple challenges. First and foremost, we have accessibility issues, right? And then we also have challenges with the support for students who have exceptionalities. But these challenges extend beyond their exceptionalities. They also have much to do with training and support for that deals specifically with the changes that we've experienced with the pandemic. So we're using technology that we haven't used before. And so we have students who already had barriers and challenges and issues, but now those barriers are even more extensive because we're all rushed or pushed into utilizing these services, and we may not have the proper infrastructure in order to navigate through that challenge.
Mhm.
So what else, what are some of the other challenges that we see? Amy, I see you on that finger up.
Yeah, but I think that, I mean, speaking to what Elizabeth just brought up, when you talk about the children who have exceptionalities and things like that, I think the primary point that we will get to is that vulnerability is not evenly distributed, right? There, when we think about, people, individuals or communities that have been more highly impacted by COVID, these are the communities and the individuals who already were vulnerable before COVID because of certain systemic economic issues, institutional issues that were present previous. I feel like,
help me out real quick. So you're using the word vulnerable, and I want to make sure that people really, they understand that word differently. Can you kind of dig into the word vulnerable and kind of give us the 1, 2, 3 on how you see the word?
Definitely. So when you think about vulnerable, we can go back to Elizabeth's her definition of children who have special needs educationally, right? Who have exceptionalities. We can talk about people who have low educational attainment previously, or who have not low educational attainment because it's something they've chosen not to do, but maybe because they haven't had the access to higher educational attainment. People who've had difficulty being able to get good, steady employment. We're talking about people who have had issues getting healthcare that really reflects their cultural beliefs, that is respectful, that is high quality. We talk about people in communities that have access to safe and affordable housing. And yeah, I had just saw somebody pop up in the chat saying, reaching bilingual families, people who don't speak the language and, really need providers and educators and, people within our institutions that can serve their needs. So when I think about people who are vulnerable, it's people who are not having their needs met, who cannot access services in the same way that many people can have their needs met.
Gotta love that technology. Can you all hear me?
Yes.
Okay, good.
Yes. Yes.
Everything is frozen. I'm just gonna keep talking. So for the type of vulnerability that Amy Hampton is speaking about is vulnerability around access. So, there's a systemic type of vulnerability that people can have even outside of their emotional connection to whatever this is. So the type of vulnerability that Amy is talking about is one that is not necessarily controllable to a certain degree, because the system will move in ebbs and flows, and then people have to kind of navigate through that type of vulnerability. So when you're thinking about vulnerability, I want everybody to understand that there's an emotional vulnerability and then there's a systemic vulnerability. And Amy is chiming in on, I guess, what we would call maybe a macro level or an organizational level type of vulnerability that people might experience. And so this is somewhat different, I think, from what Elizabeth is saying, in that Elizabeth is talking about, I think, specific support as it relates to those vulnerabilities. And then Amy is chiming in and helping us just to understand first and foremost that those vulnerabilities are real. And so sometimes I think that's a huge challenge for us, because not us, I'm saying us in terms of everybody here on here, because we have this reality that life exists outside of what we do and who we are. So we may see the system in a certain way as in terms of how that system relates to our lives and what we do. And then Amy's helping us to understand that, you know, there are challenges that people experience that are even outside of what we see every day. And so that means that we may have to alter or shift our focus in how we see or understand our system, and then really look into reaching and digging into what Elizabeth's talking about. Haven or Rachel, do you all want to chime in a little bit?
Whoa, I was ready for this. I was ready when I actually wanted to come here, wear some scrubs, my hair up, no makeup on. I want y'all to see like the pin splatter, but I said, no, let me go ahead. I just got off of work. For me, I'm a registered nurse. I work in a long-term care facility. So I take care of 30 patients a day in all aspects and ranges. Severe dementia, strokes, mental health issues, people that are born with lack of mental capabilities. I take care of them all. And when this pandemic hit, vulnerability. For me, when I think of I think those patients, like, okay, let me give you a little scenario about what a nursing home is like, okay? Before the pandemic came, let me tell you, I didn't want to be a nursing home nurse, but however, it fell in my lap and I love it. I love it. If we have anybody going to Grand Shepherd, come over, Stone Rise Healthcare, okay? So typical nursing home before the pandemic, you know, you come in, you work with your patients, you give them your medications, family members could come in whenever they wanted to, bring them sweets, treats, sit down with them from dinner. Hey, you want to go spend the night at your daughter's house Christmas? Go right on ahead. Pandemic came, shut down. Nobody in and out, no one. You know, we came in, we were wearing PPE, N95s are very fine, but N95 like brings me like, no, no, goggles. Oh, let me, someone's grandma made us masks, okay? That's where it all really started from. And it was us and the patients, and that's it. And they couldn't even leave their rooms. They couldn't even leave their rooms because the risk of this virus spreading through our building. I work around vulnerable people that are sick. They get sick with the flu. Hey, it's a little Russian roulette there. We don't know. What I found is that we dealt with severe depression from patients. We dealt with anxiety. We dealt with family members. You have to imagine, there is no more control. You know, the little bit of control people think they have, it's gone, bam, gone. And you have family members not even able to see their loved ones except through the window. And I will tell you, when you're talking about, Elizabeth, about like technology, try to teach someone's 80-year-old wife how to use Zoom. You know, it's just like, how do you get a grandchild around you? Somebody. And that created, this dynamic where people felt helpless, you know, and almost hopeless, I want to say, helpless. And then all of a sudden we started coming out of it, you know, all of a sudden those real strict regulations we have to follow, and I have to follow the West Virginia state DHHR rules. We have to follow Medicare and Medicaid guidelines. And all of a sudden they started, relaxing a little bit. People can come out of their rooms. But still, the only people that the patients were able to interact with was staff. I think they missed, and so they're able to, finally come out. Little things started happening. And then we get hit again, Then when that happens, it's like, oh my God, am I reliving the same thing? The same nightmares happening all over again? And so when I think, because of what I work in and the field I work in, is this pandemic has clearly opened up eyes, also shows truly the lack of resources we have in healthcare. I mean, when we're sitting there, and I'm telling you, I'm not, when I think about it, we had no more masks. People's grandmas stitching us masks to wear, because we had nothing. It was, all the supplies were gone or overly priced. I remember that time. Oh, don't bring my toilet paper, y'all. Don't bring that back. And so I just look at the hardships and the vulnerabilities. And for me, I look at it maybe just a different perspective, the vulnerability, the hopelessness, the increase of depression and stress. And you have to understand, the high risk population, these people, I deal with long-term care. And so these people deal with multiple medical comorbidities. Their health is pretty fragile. And, and to be faced with, am I ever going to see my loved ones? Are we ever going to get out this room? Is this ever going to end? When can things go back to normal? It can be difficult. So that was my take when people say vulnerability.
So, okay, so unpacking this. So we're unpacking. So Elizabeth comes in and Elizabeth tells us, okay, we have some challenges and some different issues that we're dealing with. And Elizabeth started really big, right? And so you saw Rachel kind of touch on and kind of grab hold to some of those things, but it's like, not only do you not have, technology, but you also have what Amy is talking about, which is this systemic, these systemic barriers and these rules that move in and out. And Rachel kind of captures that, and she grabs that with her scenario as she's talking about how you have rules and regulations that actually create these outcomes or barriers, which are a form of vulnerability, right? So you have this lack of collaborative support, you have limited self-control, you have this outcome of depression and loss of hope, maybe PTSD, or the response to these limited resources that Elizabeth is providing. And this gives us a plethora of vulnerabilities that perpetuate trauma. Trauma because rules that are being designed to keep society safe as it should be are actually creating health challenges and additional vulnerabilities outside of those that already existed. Haven. Yes.
Hey, hi. Wow. First of all, my mind is blown by all of you, and I've already learned so much. And it is storming here in Chantilly, so hopefully y'all can hear me. But I kind of wanted to talk about a different lens. So I work in the NICU, which is the Neonatal Intensive Care Unit. And we have been very blessed in some ways in that the transmission of COVID-19 to newborns has been really, really low. I work in a 108-bed NICU, and I don't think we have seen any positive cases. We've had infants born to parents, and that creates its whole set of protocol, but we have not had any neonates that I know of. So in some regard, we've been lucky. I think what's happened is that the underlying trauma of the NICU has been exacerbated by COVID. And so when I talk about trauma in the NICU, we're starting with this traumatic delivery. It is unexpected. It is often medically unstable. And so that's the start, months early, whether it's a premature baby, whether it is a sick term baby. And then we're adding like financial stress. I have a colleague who refers to our babies as $1 million babies, and she is not exaggerating. We are talking about intensive care level costs. We have patients, our micro preemies can be there 3, 4. The oldest patient I've taken care of was 8 months, and he was not getting discharged home. He was going to another hospital. And so that is 8 months of ICU hospital bills. On top of that, we have things like lack of emotional support. We just don't have social services in place that are necessary for these families. We have impaired bonding with these medically fragile babies. You know, if you can't hold your baby, if you can't feed your baby, that loss of control and that lack of like even the first moments of skin to skin, which research has shown is so big, it's gone. And finally, like we have divergence from the plan. You could have the best birth plan. I think most parents do. And it's gone. And I think that I'm not exaggerating when I say that every culture has rituals around birth and certainly around death. And we've taken a lot of those. We do what we can to accommodate, but oftentimes we are unable to. And so I think you take this environment, and this is something I have a lot of feelings about. And so we look at the numbers, which I can send studies if anyone is interested in my sources. But when we talk about it, 60% of NICU parents experience symptoms that could be classified as some form of PTSD. 70% of NICU moms experience postpartum depression. 1 in 10 NICU dads experiences increased levels of anxiety. And so we've got all this. And then on top of that, we've got COVID. So now your premature baby with no immune system, you're worried to even come in and see your baby because what if you were infected? And I think that, you know, thankfully we have allowed, parents are always allowed at the bedside 24 hours a day, 7 hours, like they are part of our care team. But like I said, we've gone 3, 4, 6, 8 months without siblings meeting their new sibling, without grandparents meeting their grandchildren, without aunts and uncles. And of course we will make exceptions, end of life and so forth. But I think like, you know, you take the financial stress of the pandemic, you add it to the financial stress of the NICU. But mostly what I would say is you take the emotional vulnerability and stress and trauma of the NICU, and then you add the pandemic on top of it.
So I want to, so a little bit more unpacking, right? So interesting piece here. Haven delivers this reality that you have situations that were already stressful, already challenging. And then you align this with a combination of what Rachel is talking about here, which is the, I think the emotional stress and the triggers that come from that emotional stress. And then Haven adds to this conversation about financial or fiscal barriers. But most importantly, I think from Haven's conversation is this idea of a lack of or a loss of control around rituals and diverging from the ability to actually plan. And so our most organized people use these planning skills in order to make everything better. And so if you have a pandemic that disallows those plans to occur, then you have no normal. And I think the key that Haven is delivering in this conversation is that even when you have these difficulties, you have no normal, and you have a loss of a capacity to plan. And that is, and then some key ideas that Haven introduces are the rituals around birth and the rituals around death, and then how isolation also impacts your capacity and your ability to plan and to stay emotionally sound by having those, like we talked about, the whole idea of starting this training and starting with filling your cup and doing the meditation or doing the exercises and giving yourself the ability to breathe. People sometimes, especially extroverts, they take energy from other people and they use that energy in order to build, in order to keep their cups up. So what happens now when you are the extrovert in the job and you're having to carry lots of weight along with, like Haven said, the stuff that's going on at home, right? So it's not just the stuff that's happening, you know, it's the stuff that's happening in the NICU, and it's the stuff that's happening at home. So we can apply that to a lot of different sets. We could to any employment, any place of employment, right? That you have not only the stressors from home, but now you're carrying weight from something that's happening on the inside. And now you have to be responsible without the ability to plan and with the loss of your own self-control while dealing with other people who are vulnerable as well. So I think that first question, I don't know, like, do you all feel like you learned a lot? The audience, the people who are listening, talk to us in the chat. Do you have any comments or anything that you would like to add in the chat about what we just talked about? We want to hear your voices too. So go ahead and then use that chat and chime in and share your information as we continue to navigate through the questions. We want you to be a part of this too. So please bulldoze that chat. As we're communicating, as you see different ideas, make use of that and become a part of this conversation, because it can be a dialogue through the chat as well. I would
like just to point out that one of the things that came out from the other three participants was that they all brought in an example of how vulnerability is not equal or is not evenly distributed, because we are talking about children who have special needs. We are talking about elderly individuals who are, that need special care, and we're talking about premature babies. So these are perfect examples of how our vulnerabilities are already existing and how COVID and this pandemic has amplified some of these vulnerabilities for these populations.
So, okay. So does everybody feel comfortable with your responses? Do you feel like, did you hear something? Did you hear something else? Did I miss anything in unpacking? Did you hear your peer say something that you feel like you feel like it needs to be, we need to dig into it a little bit more? You all feel good? All right, I'm keep going. Rachel, you okay? You got something?
Yes.
No? Okay, all right. So now Amy touched upon this, and so we're moving in Amy's direction a little bit here with this next question, because we're going to talk about institutional barriers or challenges. And so I need to unpack this question a little bit for the audience so that they understand, because sometimes, so the question that we have on deck is, what are the institutional barriers or challenges that you've noticed that stop us from doing something about these things that we just talked about? And do you think there have been any progress? But I want to unpack the word institutional for everybody. Obviously, I do sociology. An institution is a system where the rules and regulations within the system impact people in terms of who they know and what they know. Also impact the roles that they play and the identity formation that people are able to have in those roles. And then it affects your ability to carry your swag or your prestige or to be the person who you have to be every day. So examples of institutions would be the economy, the political system, religion, it would be also the media, and so on and so forth. So those are institutions. And then you have barriers that exist within systems or organizations that kind of evolve around those institutional changes that are happening every day. So we've talked about a lot of things already. We talked about technology, right? We talked about, we haven't talked much about the media, and that all of these things matter, note. So all of these different institutions, they have rules and regulations and new ways of doing things that come into our organization. And then we have a set of ways that the organization is going to tell us to deal with that stuff. So, I want you to think, think about this, as you're navigating through the question, what are some of the barriers that we see? Where are these barriers coming from? Where's this stuff coming from? And has anything been done, or are we all just going home looking like somebody stole our bikes? So let's talk about that. Who's going to go first? And I see some questions in the chat. I'm going to integrate them.
I know I just spoke, but I can start if no one else.
Yes,
so I had 3 different, but I'll start with one just so everyone else can speak. But what I think of when I think of barriers and institutional issues, I think of legislation. And, I work with babies, but hopefully you all will let me take the mic for families in general. And And I think about family medical leave. So, federal law says 12 weeks unpaid throughout the year. Now, companies may have different maternity, paternity leave policies, but the minimum that you're going to get is 12 weeks, which, okay, so maybe that sounds like a lot. I'm sure anyone who's a parent would say, no, it's not. But, okay, so you're sick a couple weeks, there's a couple weeks, and then you're pregnant and maybe you can't work those last couple weeks. Maybe you've got complications. You end up on our high risk pregnancy floor with preeclampsia. And so now how much of your time is left? And, again, I talked about these patients who are here for months, are 23, 24 weekers, babies born at that gestational age. It's a long road. And I see commonly those moms and dads, if they're given paternity leave, they save their leave until their baby comes home, which makes sense if you think about it. But at the same time, now they're juggling everything we've already talked about and trying to work so that they can be available for their baby when their baby finally gets discharged. And so that's my little soapbox for like pushing for better family leave. But in terms of progress, I do think there is some legislative progress. March of Dimes is a really great resource if anyone is interested in me geeking out over perinatal nursing. But recently, California, of course, it was California, passed Senate Bill 65. It's called the Momnibus Act, and I would love to see it adopted more places or maybe at a federal level to improve perinatal outcomes with like specific proponents towards racial disparities in perinatal and infant health. And so basically they established a fund for education programs, I think specifically midwifery, and they were prioritizing applicants from underrepresented groups and underserved communities. They're exempting pregnant people from the CalWorks welfare to work requirements. And then they added some in their Senate budget for that year that includes extending Medicaid coverage to the first year postpartum, which is great, as well as covering doula services, which we talk about those rituals. Having a doula, a layperson who has received training to be there can really be a protective factor for these parents if that's something we can incorporate in your birth plan. And then they are also piloting a guaranteed income program, and they're going to prioritize pregnant people. So I would love to see more legislation like that passed. I think that would be wonderful.
All right,
I find it really, oh, I'm sorry.
Go ahead.
No, I find it really interesting what he's saying, especially on thinking about legislation, the leaders, right? There are people in these positions making decisions, and a lot of times they're not actively involved or engaged in what's actually happening. And if we take that over to education specifically, we're finding that there's a lack of diversity in the leadership, right? And the leaders are making decisions about diverse at-risk populations, and they're not a part of that vulnerable population. And specifically, when we think about West Virginia, there are 2 cities or towns in West Virginia that did not experience any population decrease. In fact, it was increased. So Martinsburg and Morgantown. And you have a lot of people like for Morgantown, it'd be like Pittsburgh and the city areas. And for Martinsburg, we have a lot of commuter transplants coming from the big cities in Maryland. And a lot of these people are diverse in their ethnic background. But when you don't have the leadership in place that has a cultural competency and understanding, we're creating even more barriers, right? Because if you don't have an understanding on these ethnic and cultural backgrounds and these traditions, like Haven said, right, then when you're going to educate and create structure within the classroom, then you might be thinking that a child is acting out or behaving in an inappropriate manner when literally that's a part of their culture and where they're from, and that's how they protected themselves on a day in and day out basis. So I think it's really, and to navigate that, I think providing, I love this conversation. It's very similar to the medical aspect. We want to increase educational opportunities for those persons who are involved in the system and creating more recruitment opportunities. And, across the nation, we're experiencing a loss of certified and qualified educators, right? Because you don't necessarily have to have formal education teaching to be a qualified educator with additional training. And so it's really important that we work on increasing our recruiting and maintaining methods and getting the diverse or well-rounded, competent educators and leaders within education.
Does anybody else want to jump in before I unpack?
I was going to, and I was thinking Elizabeth was saying toward the end, one of the barriers that I find is that we don't have enough qualified nurses, or we don't have the money. Let me just say it's about money. It's always about money. And we just don't have that. You know, we don't have the resources to go to school. And nursing school is hard. You know, when I say hard, it's like you're dead your whole time. I was very blessed in the fact, I can only speak for me, that I had to stay with my dad. You know, I was a single mom with kids. There is no way I could have been a nurse making $8 an hour and going to nursing school. You know, so I had to sit there, stay with my dad and go to nursing school. And so I had an opportunity, but I think about all these other people out there that would love to be in the field, but you have to, you know, be registered, and you have to pass, get your degree, and they don't even have that. Guess what? They got to go to work and they got to make $8 an hour, and they got to sit there and take care of the kids and make sure they got food and the lights on and struggle. But we don't have opportunities for people to sit there and say, hey, don't worry about it. We want more healthcare workers. Here's a grant, go to school, get your education. We don't have that. And then you wonder why in this pandemic, the whole boom, what? We were on fire. We were on fire, you know, and the education system. You know, I have kids in Berkeley County schools. My son, my youngest, is autistic, you know, so I understand what Elizabeth was saying. That was different, but at least I had the opportunity, you know, to be able to help him navigate at home, but about families that didn't have that. And so when I think about institutional challenges, always it goes about majority of resources that is provided by the government is not spent on the right areas of society. 2 cents. So
I won't ask you to get political, Rachel, because everybody knows that right and wrong is a very subjective statement.
Yeah.
However, right, we do have to unpack a little bit more because we are providing context. Haven talked to us about some places that he believed the money could be spent, you know, in a right way. Rachel tells us that we just have a money problem, period. So you get into this question of where's the money spent? Is this the right place or the wrong place? Like, how do you figure that out? Elizabeth gave us some really interesting food for thought. Elizabeth says that cultural competencies and understanding the communities of people who we have to work for, that is vital in terms of helping us to be qualified, period, to do what we have to do. And so when you talk about, Rachel, what is the right way to spend your money, or what's the wrong way to spend your money? There's some people that disagree with Elizabeth. They may not believe that understanding cultural competencies is the right way to spend the money. This is why we're here to have these types of conversations. You know, this is why we're here to delve into this. So I do want the audience to understand that we're not trying to tell you what you need to do, the right thing or the wrong thing. We're just trying to give you options, and Rachel just threw it out there, just straight up threw it out there that she believes that money's not being spent in the right way. So maybe you agree, maybe you disagree. Key here, making sure the rules apply. So if the rules are not applicable, perhaps we won't be spending our money appropriately, right? Because the rules don't align with what's actually going on. But how difficult is it to change the rules? You know what I mean? Like, how difficult is it to make the adjustment when everything's happening so fast? Everything's happening so very quickly. But at the end of the day, we have groups of people who have opportunities and we have some people who don't. So we really gotta hold on to that idea for a second. And I want us to just pause and think about that. So everybody just take a pause and think about it. When you get up in the morning and you get ready to do whatever it is that you have to do, what opportunities do you have that the other person, that someone else may not have? You know, what is your situation? What are your conditions, you know, that you experience on a regular basis? And I mean, that's about cultural competence, understanding cultural competencies in itself, like understanding difference, understanding that difference actually is real and that it actually exists. And so for some of us, we're stuck on these rules that Haven's talking about, right? And this is the difference between mindset, okay? So in sociology, we talk about mindset. We talk about liberal versus conservative, right? Mindsets. And that means that some people are going to think quantitatively and based upon specific, distinct rules and regulations and lists that are there, because I can see that 1 + 1 = 2. If I follow these rules, this is going to be the way it's going to go. And then you have a more qualitative nature where you're more subjective or liberal in how you're looking at things. And in this case, you might say stuff like, well, you know, we need these things. We want these things. These are things that are perhaps missing. You can't quantify all of it, but you know that something doesn't seem right. And sometimes you have to look beyond yourself. Sometimes you have to look beyond yourself in order to force yourself to think qualitatively and quantitatively. So I want to challenge everybody. One of the biggest problems that I see in the pandemic and being able to understand the difference between right and wrong is that some of us are trapped in either quantitative thought processes or qualitative thought processes. And so we're going to bump and we're going to beat each other up because we're trying to figure out what's right or wrong, but we aren't really fully assessing the situation sometimes because we might just be thinking about our quantitative health and not really understanding the qualitative circumstances, you know, not understanding the day-to-day lives and different experiences and not delving ourselves into it because, as Rachel said, maybe because it's just hard. Maybe it's just hard. And if it was hard to do cultural competencies before the pandemic and to understand difference and to navigate through the stresses that people have, that you don't have, that you might not have to deal with, now we're asking you with your half-empty cup to go and think qualitatively and to think about some of these challenges and to support people that maybe you don't even want to because it's hard. Not because you don't want to, but maybe just because it's hard or for whatever your reasons are. Just think about that. Just unpack that. And then Amy's going to talk to us.
So some of the things that you're saying, Quita, are so right. And I have so many things that I want to say that I'm not sure that I can even speak to all of them because now my heart's pounding. And but some of the things that I want to bring up is I really agree with what you all are saying, that I think it has a lot to do with legislation. And I think that the legislation has a lot to do with our funding and where our priorities are, right? So when I think about this, I think about, okay, we have a lack of teachers in our county. When I'm talking about Berkeley County, because that's where I live. That's where my kids go to school, right? And so I can only speak to that. So we have a lack of certified teachers in our county. They are struggling to meet the needs of our students right now. And so why do we have this lack of certified teachers in our county? Well, one is the pandemic, and the pandemic has shown a light on this, but this was an issue previous to the pandemic, but the pandemic is peeling back the layers. We're seeing this more because of what we are dealing with right now in the midst of COVID. We had a teacher strike in 2018. It was considered successful. We were an example for the nation. And we, after that teacher strike, were 48th in the nation for teacher salaries. So if we want to put numbers, our quantitative with our qualitative, I think that that is a really good example of why we are struggling in some, at least in education. I can't really speak to nursing, but that's, what I'm thinking of in that area. When we think about qualitative and qualitative, right? We think about voting and we think about, okay, how, Dr. Howard Bostic, I've been calling you Quita, now I'm going back to Dr. Howard Bostic. She was bringing up the fact that how easy is it to change these things? And this is something that social workers are focused on, is how do we make social change? How do we go beyond our specific client system to make change to larger systems, right? Beyond the individual. And so when we're thinking about that, okay, we need to change this legislation. We need to push for better legislation. The legislation like Haven brought up, because that got me excited, right? I'm happy about that possibility. I'm like, how can we work for that? So, but then when we start to think about voting rights, when we think of this on the macro scale, we have had over 500 different laws proposed throughout different states to limit voting rights, y'all.
Yeah.
Now, I'm not getting political left, right, Republican, Democrat. I'm registered independent, but I need us to be real about what it is we are looking at and how easy is it going to be for us to make change if we are trying to limit other citizens' voting rights. I also want us to think about, okay, so if we were thinking about how difficult this pandemic has been for us, and we're thinking about, we have to think outside of just our box and how it's hurt us, what were we doing at the very beginning of the pandemic when we were trying to find toilet paper? Because I wasn't stocked, right? and when people were like, I never did an Instacart and I never DoorDashed anything, but people were doing stuff. And what did you use? We were using credit cards. We were using our debit cards to do those kind of things. If you're an immigrant and you don't have a bank account, you couldn't DoorDash. You weren't Instacarting. So we need to think also on those micro levels. How did that affect people when they were trying to get food and basic needs met at that point? And what level of risk did they have to take to be able to get those during those time periods, right? So I could go on, but I just feel like, we're trying to, connect our qualitative and our quantitative and look at our big system and our little systems together.
So important. I bet Rachel's thinking about that social stratification class she took years ago.
I know.
We were talking about what I teach this class, y'all. It's called social stratification. I don't know if you ever, they're actually on Facebook. There's some lectures if you're ever interested, but in this class, we talked about these things called modes of production. And we basically talked about how technology in particular right now, or certain tools are used during certain periods of time in order to make money, in order to generate profits. And we took the class through the history of those modes of production so that people could understand how change happens and how prepared you need to be in order to create that change. And we talked about global technology, didn't we, Rachel? And we talked about how if you are not prepared for that mode shift, if crisis comes, those people who do not have the tools that are necessary in that particular mode, they will fail, they will fall instantly, they will fall fast. And will we be prepared as a society for that? And not as quick as we talked about that in the class, a pandemic happened, right? And so these things are very, very important. How prepared are you? And Amy's talking about this, but is it really clicking for people? Like, do people understand that the average person may not be prepared for tomorrow? That the average person that we're dealing with in an at-risk population, that they might be prepared for what's going to happen 10 minutes from now, and not even an hour from now, not even a day from now. Before, I remember people talking about, oh, this day-to-day life. I'm trying to figure out what food I'm going to eat today, right? People are trying to figure out how to get toilet paper for this 5 minutes from now, okay? Like, there were things happening where we shifted from preparedness just in the day-to-day life to an hour for hour by hour preparedness. And so looking at that change and how systemic or how structures exist within that change, within even new tools that you have to use, what do your survival mechanisms look like when you move from day to day, which we complained about people being unprepared in day to day, to them being minute to minute and hour to hour? I'm going to go to the store now. I might get sick and die from going to get groceries. And how does that impact our mental health? When we were already, some of us, underprepared, not even unprepared, underprepared. Like walking around like your whole day is like this. Like this is what you do all day long. You just spinning around and you have no idea what's really going on. You got day-to-day vertigo. And can we as professionals, right? Can we stop for a second, even outside of our whole own lives, and see, why did this person respond this way? Because they've been spinning all day. They've been spinning all day, but you're getting mad because you got things together because you were prepared. And all you can see is their response while they're spinning. You don't see them spinning because you can't see that. You can't see that because you won't allow yourself to step back and understand what's really happening. And the panels talked about a lot of those things that are happening. How many of your clients, how many of your students, how many of your patients are spinning, but you can't see them spinning because you were prepared?
Can I
All right.
speak on that real quick?
Speak on it.
Because I work so close, like I do home visits. I told Amy, I feel like I'm an educator / social worker because I do home checks and visits and weekly calls to families who already are struggling with access to food, basic toiletry supplies. Like we have a pantry in the Berkeley County school systems through our parent engagement office where we help them get these day-to-day needs, right? And it's my job to not only, along with my co-workers, to supply these personal needs, but then also help mitigate and navigate the challenges with the educators, because educators don't understand why the kids are coming to school and acting up and doing all these things. And I'm like, okay, well, this is what's going on at home. But I often feel like it's a little more challenging to constantly have to coach an educator to understand that they have to remove the blinders off their eyes and realizing just how much these children are facing and navigating at home because of the lack of access. So if we're not understanding and having that awareness and acknowledging that everyone is not in such a blessed or can easily access these things day to day, they're coming in and they're going to have attitudes. They're going to have issues. And these parents are calling me crying, saying, I don't know how to get through the day. Like I'm spinning. And on top of that, I have to help my kid navigate school. And it feels like the people in charge just aren't getting it. And on top of having to help them learn something, they have these medical complexities and disabilities, and and the child doesn't understand, and then the parent doesn't understand, and they're dealing with it's like everything's just so compounded for them day in and day out. They feel like they're suffocating and they can't breathe. And then I get them and I'm like, hold up, it's okay. You're not alone. We're here for you. And it's my job as the Parent Engagement Resource Center coordinator to not only support you in this journey, but also help educate the educator so they have a greater cultural competence, because culture is more than just what we look like on the outside. It's where we live. It's our community. It's our access to finances, right? So yeah, like that just looks.
So can I just have just a news flash for a second? We're going to just pause for a second. Emotional intelligence is the ability to perceive, use, understand, manage, and handle emotions. So people with high emotional intelligence, this is what we're focusing on. So I hope everybody understands that this conversation was about emotional intelligence, and we're pulling you through vulnerability. We're pulling you through institutional barriers. We're pulling you through the ins and outs of different fields to help you to understand how valuable and important it is to not only recognize your own emotions and those of others, but to use your emotional information to guide the thinking and behaviors of others, but most importantly, to be able to discern between different feelings and label them appropriately, you know, And so we have this huge challenge because of the pandemic. We have a hard time adjusting our emotions and adapting to the environments that we have to move in and out of, which are stressful as heck for everybody. So something stressful is happening for everybody, even the most prepared people and the underprepared people. But we're asking our service workers to do such a big job, so much bigger than what we were already doing. And it was already difficult before. It was already difficult before. But emotional intelligence is so important. And it has much to do with the very topics and ideas that are being introduced by our panelists. So just again, we have Elizabeth Mobley, we have Amy Garzon-Hampton, we have Haven Sylvia, and we also have Rachel Tizer here speaking to you about emotional intelligence in the social services. And so now what I would like them to do is to just talk for just a little bit about, I think, some of the safe spaces that we think we may have for populations who are at risk, and even more specifically, BIPOC populations, LGBTQ populations. So this is, people of color, diverse backgrounds. We talked about financially challenged particular groups, and we talked a little bit about communities, but we haven't delved specifically into particular at-risk populations. So how can we make things better? Like how can we create some safe spaces that are supportive? So we talked about the challenges, but now what can we do? So what are some takeaways, I think? What are some things, little or big, that individually we can do? Help us.
Would it be okay if I actually pinged off what you said about the spinning chairs and then went into the question about
anything you want? Is this all
Thank
your world, Haven? Do it.
I just wanted to talk about, like, sometimes I feel like as caregivers, and I might get a little emotional, like, we can see that the chair is spinning, but we can't do anything about it. Like, I think so. We have something, I think my unit is unique, although Rachel, I feel like you probably will see a lot of like the similarities when I'm talking about it. And like, you're admitted to the hospital with pneumonia, maybe you're there a week, you move on, you put a bad day behind you. Like I said, like my parents are there with their babies for months. And Rachel, I know it's even longer for you. And we have this thing called primary nursing, which I think is a protective factor. I think it's really wonderful, where because we know that we are there for so long, like certain nurses will sign on to a baby and a family early in their stay and follow them all the way through. And that can be really, really beautiful. Like there are nurses that go to birthday parties. My first primary patient, mom texts me pictures of him working on his head control. I got to see pictures from his half birthday recently. They were super cute. And it's beautiful. But then there's also the palliative care primary that I had. And you see these parents, I work night shift. And so I'm there 3 nights a week with these babies, sometimes for months, and their parents, because when we treat the baby, we treat the whole family. And I'm watching them spin, and I know that they are hurting, and I can't do anything to help them. Like I can offer some things, but I'm never going to revive your baby that we are going to withdraw life support on. Even your micro preemie that is going to grow up, you're going to see so many hardships. So many of our kids go on to special services like Elizabeth has. And so I feel like that can contribute immensely to caregiver burnout, because like you carry this stuff, you go home, like my wife can tell you that I've come home and I've like cried about patients. Maybe that's me getting a little over attached, but like, how can you not? They're babies. But to actually answer your question, thank you so much for letting me go off on that a little bit. I think it's really important in the medical field to acknowledge the history. I think acknowledgement has its own power, and I think we need to acknowledge both in history and education and practice, the racism, particularly racism and the homophobia, transphobia, et cetera, that is in medicine. Mm-hmm. Again, really coming from like a maternal newborn lens, parental newborn lens. So much of gynecology has super, super questionable ethics. We talk about like 1800s in the US and how, white medical men viewed, there's a historian out of Berkeley Deirdre Cooper Owens, I think, who terms this phrase super bodies about Black women's bodies, and the idea that they at once, like, experimenting on them essentially can glean knowledge that can cure all women, but at the same time these women are promiscuous, they are immodest, they cannot feel pain, and so like this duality, and like, I mean, there's nothing to say beyond that is horrifically racist, and that's where so much of our gynecology comes from. I think of more recently with birth control. The first human study on birth control was done in public housing projects in Puerto Rico in the 1950s, and informed consent, super questionable on that issue. And then once we established that further, birth control pills, which super big proponent of, but went right into the eugenics movement. There's so much racism in medicine, and I think like it's just not talked about in education of nurses. And I think like we need to acknowledge the history. I think moving on to like LGBTQ and intersex populations, like in newborn medicine, we need to acknowledge the history of intersex surgeries to normalize babies' genitals. I think that people think that being intersex is a very rare condition, but Amnesty International would tell you that it is about the same as being born redhead. So, you know, think of how many redheads you know. And for anyone that doesn't know, being born intersex is just being born with sexual characteristics and reproductive organs that do not fit into our male-female binary. There's so many different classifications of this, and there are a lot of like professional groups that have spoken on like what the recommendations are, but we have an awful history with it. And I think even in the present, so like 1 in 10 babies is born premature. When we look at Black women and Black newborns, there's a 50% increase. Thank you so much for putting all of this up, Dr. Howard Bostic. I do have other links too. But even Black newborns are more than 50% more likely to die before their first birthday. These are horrific. We are, for a high resource nation, we have the lowest parental outcomes. Like many people, but one of the lowest. Like there is no reason that we should have these for anyone, but like particularly these marginalized communities. Sorry, that was really long.
No, it wasn't. It was absolutely
That was perfect.
And everybody keep going. Don't be afraid. You all know your voices are valuable and important. So use them. Use them. We will all get an opportunity to share. I'm going to do the same thing as you all are chatting. If there are any resources that I can provide to help our listeners to navigate through some of the topics, I will provide those. So listeners, please open your chats and copy and paste these resources so that you can take a look at them later if you would like to do that. So let's keep going. So yeah, let's keep on going. Let's keep moving with this. And the question that we're asking, what we're talking about now are how can we create safe spaces for our at-risk populations, and you know, how can we be more supportive? What can we do to support these populations? Mm-hmm.
I think that we should, I mean, in my opinion, and this is definitely just my opinion, I think that we have to be realistic about the creation of safe spaces. I think that we can create safer spaces, but I don't know if right now there is a truly safe space. I don't know that I could tell someone you're safe in this space and guarantee that they would really be safe. And I have to be very careful about making guarantees. So I feel like, you know, Haven, you hit that nail on the head really well, in talking about acknowledging where we stand in our social selves, in our identities, how people perceive us, the thing, you know, the way we show up as Quita has said, you know, many times, how people perceive us, and also acknowledging, you know, what do we get from this, and how do other people perceive us, and how do other people get different outcomes just based upon how they show up. So, you know, talking about, you know, what is happening, the disparities in outcomes, in birthing outcomes for African-American women versus white women. It's data. This is real. And I think that these things need to be stated. And I think that, talking about this over and over again is the only way that people are going to begin to understand it. When we think about this in terms of COVID, the African American, the Latino, and the Native American communities are the ones that were hit the hardest with and bore the greatest burden around the infection rates and the death rates in COVID. So when we talk about lifting the veil and really seeing what's going on, we saw that these communities really have had to deal a lot worse with the pandemic. A lot of our frontline workers, right, were also from these communities that continue to have to go out and work and put themselves at risk. We also need to talk about social determinants of health. And this is where social work has been for a really long time, talking about, this isn't about just exercise and eating healthy and, going to see your doctor on the regular. This has to do with safe housing. This has to do with, good education, access to good education. This has, is there investment in the community and things like that, right? And so we have got to be able to look at these things as well. One of the things in social work that we really focus on is, instead of just talking about institutional or social welfare, we talk about relational welfare. And one of our primary values is the dignity and worth of the person. And I think that when we really get down to it and we focus on the dignity and worth of each human being, relationships is where change happens. Relationships and genuinely caring about each other is where we really can make change, is where we really can move things forward, but it takes time and it takes a lot of effort. And so that relational welfare, as opposed to social welfare, is a really, really valuable thing. And it's harder to judge from there.
Can I piggyback off of Amy?
Sure, do it.
Thinking about that relational component, a lot of my, because I primarily work with parents of kids with special needs and medical exceptionalities. And so I'm getting, like Haven mentioned earlier, I'm getting the kids that were in the NICU. I'm the mom of a kid in a NICU. So I'm dealing with parents who are, their lens is trauma, 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 trauma. Right? From them almost losing their lives, their kid almost losing their lives. And now they have it is not a burden, but for them, because it's a trauma lens, right? It's the burden and responsibility of identifying resources and the people who are not going to look at them like they're a burden, because most parents of kids with significant needs who are caregivers, right? Because they already know that 9 times out of 10, when their kid hits 18, they're not going to go off to college or go start working. Their kids are going to be with them forever unless they find alternative placements. So it's this constant lull and feeling like, okay, I'm in this alone. So now I'm isolated, even if there are resources available. I don't know how to reach out or put myself in a position for people to reach to me. So then their kids start school. And parents are getting upset, going back and forth with the teacher, but really they're just looking for someone to acknowledge the pain that they've experienced and create relationship with them. Like, to the point where a grandma, I call them grand families. And we have a lot of those in West Virginia, where you have parents due to drugs or whatever, most likely drugs in this region, right? Unfortunately, no longer have custody of their grandkids because they were born addicted or fetal alcohol syndrome is involved. And then you have grandfamilies who go from the NICU to taking these kids home. And then now the kids are in the school system and they're dealing with us. I had a grandma who had 2 10-day quarantine sessions with 3 boys, 2 of which were identified with significant behavior difficulties, right? So they have IEPs for behaviors and they were in the NICU at birth. And so she's isolated. She can't drive. No one's reaching out to her. She feels like the school system doesn't understand. And then I get in touch with them because we're really trying to push the fact that there are resources and people to just be here to hold your hand. And she said, thank you so much for bringing the activity. I did a doorstop, a front door drop off. And she said, thank you for bringing these to my home. But can you do me a favor? I mean, I know you're an educator, but can you call me? And I said, what do you mean? She said, until I feel better. And not that she was sick, but mentally and emotionally, she did not feel good because of this trauma. She's low income grandma, right? Who does not drive, who's stuck in a house and getting the rough end of the stick with her grandboys. And she said, can you just call me? Can you just see about me? Can you just have a conversation with me? And so I think if we start, like for me, it would be working with educators, but nurses, social workers, if we're going to branch out and increase awareness and understanding and this competency, it also goes through. So we got to take care of the caregivers, not just being grandma, mom, or dad, or whomever is taking care of the kids, but our nurses, our teachers, our social workers. Are we doing the emotional and trauma-informed care for them? So that then they're better prepared to do this with the populations that they serve. So if we're caring for them and giving them opportunities to mitigate the burnout and the heavy, because burnout is so real and no one wants to talk about it. No one wants to address it because we're this pretty buttoned up society. But if we acknowledge it, put a name to it, become aware of it, then provide the resources for those persons giving the care, then they can take what we've provided them and then give it to their patients, their students, the parents of the families. And then we can all become better. We can all become more stable. We can lessen that PTSD, right? Because COVID created that in people. And then if you're dealing with at-risk senior citizens, persons in general, NICU parents and families, the trauma lens is real. So if we're providing the care for everyone top down, I think we'll become a more healthy society.
I agree. I know for me, when I looked at that question, that when you sent, I had to think about my population of patients that I take care of. And I take care of a population that grew up in a society that said, you don't talk about what's going on in the house. If you were not normal, you got locked up, you were institutionalized. I take care of people that couldn't really be themselves because no one would listen. I feel, this is a man's role, this is a woman's role, this is a child's role, and dare you be different. What I found for me that works with my population that I take care of, old people, I love them, is that I just listen. I really just listen. And what I found, when people realize that you're listening to what they say, they began expressing more. I did not know that some of the women that I was taking care of worked in the factories here in Martinsburg. I did not know some of the women did not have any high school diploma. They, married at 14, 15 years old, had kids, went to work. I deal with men, there that have either gone to the war or have lost loved ones in the war. We have a patient. I thought when he was talking about his brother, I thought he meant his brother had passed away recently. No, his brother had died in Vietnam and they still don't have a marker for his grave. But they have no money. That family don't have no money, And so when I look at the people that I take care of, I have to, and I think this goes back to like caregiver burnout. I always tell myself before I walk in a room, let me be the peace and the calm in the storm. Let me send out the positive energies. Let my heart be kind. Let me be honest. And the theory, it's better to understand than to be understood. And that's how I approach how I handle my patients. But I do feel that if we don't have these conversations when it comes to safe spaces, they're not going to exist. They're not. And so we have to have these conversations. We have to bring into light. And what I found that I am pretty glad in school, like I said, my children, go to Berkeley County, and they seem to have a more understanding of safe spaces. And so I see this generation growing up with more awareness, tolerance, the ability to help others. And I find that beautiful. And I think for me as well, a lot of this deals with acceptance. You know, what can I change? What can I not change? Do I have control over it, or if I don't? And I think that's, for me, has kept me through this pandemic emotionally and mentally, is saying there's some things I can change and there's some things I can't, and I have to be able to accept it, you know, and all I can do is the best I can. And I can try my hardest, and I can advocate for my patients. I can see, you know, and for my own self, I know my triggers. I know I have to go to therapy to talk, you know. I know, you know, to me, communication is so important. And I tell people, you know, I might not know what I'm going to say to you, but I'm here to listen. Okay, I'm here to listen. And I think and I'm for that theory that, you know, you hear about it. Why do we keep treating a sick society? Why don't we make our society well? You know, let's start where people are well. Let's promote wellness. And hopefully in the future that will come.
All right, so I want everybody to understand that we've been talking for an hour and a half. It doesn't seem like we've been talking for that long, not to me, because I love listening to what everybody has to say. I sent a link. I tried to send a link out about mental health and mental health mattering and tips for wellness. And it piggybacked on what Rachel was talking about, but the link only opens on my computer. I don't know why my computer is so special, but I can maybe try to see if I can get that for everyone. You all have you put your name and an email into the chat, right? So I hope our viewers have put their names and emails into the chat so that you could receive, you know, information. I do want everybody to know that tomorrow we have a session that is just like this one, very similar, except specific to criminal justice and looking at victim advocacy and looking at populations who are punished in society and those people who are put in position to punish or to support or to participate in restorative justice, so on and so forth. So we're going to be taking this conversation to the next level, and you can come hang out with us on campus. If you want to get out of the house, if you're local, you can come to Shipley Hall, which is, you go into the Frank Center, which is right next door to the Shepherd Wellness Center, and then walk right up the hallway. Shipley Hall is right inside of the Frank Center if you want to come in. We'll have Zoom and we'll also do in person. But if you just want to get out and for the evening and just, you know, meet some, you know, amazing people, come on out tomorrow for the part 2 of this. And then on Thursday, oh my goodness. Every semester we have a leadership training for DEI, and you meet these phenomenal speakers that you're like, whoa, when you hear them speaking. If you said whoa tonight from this group, you wait until you get part 2 and part 3 of those whoas. So we got more whoas coming. Make sure that you register for that conference. If you can't register for some reason, send me an email. I think we need to change the time on the registration link so that people can go in and register, but this is my email address. What we're going to do is we're going to send group A and group B links to you all so that you can follow the workshop links. So if you've registered for the conference, we're going to send you a little guide so that you can navigate through that training and know where to link in or out. The link to access the training, the first part that we'll have with the keynote, is the exact same as this link that we're using right now. So if all fails and you somehow can't get registered or whatever, use this exact same link in order to have that communication. We do want to thank Stubblefield so much. Thank you so much, Cindy, for providing support for this program, for supporting this. We are so grateful for Stubblefield Institution and the opportunity to bring these amazing people here. I do want everybody to understand that when you have panels like this, you can't talk about everything, you know, but our goal is to plant the seed plant seeds, and we've planted so many seeds. If we look back, even in the chat, some takeaways that we need you to have from this event. We need you to be thinking critically about vulnerability, just different types of vulnerability that you might experience. And we're talking about you experiencing this and other populations experiencing this. We're talking about structural vulnerability from the rules and regulations and the policies and procedures, and really thinking about how the job can make life outside of the job more challenging, but being able to deal with that. And Rachel said it so eloquently, we can't fix everything. Like we can't, everything is not in our bandwidth. It's not in our reach, but we can do our very best. We can do the best that we can do. But we do want to think about how we continue to be emotionally healthy and spend some time actually thinking critically about that. In order to fill your cup, you have to actually be present in the situation and with yourself, and to understand that the way you did things before with the planning and processing, that you have to do things differently now, because this pandemic is creating a totally different, Elizabeth said it, she talked about the shades, that people have to take off their shades. In sociology, I talk about just sunglasses, that everybody has a different color lens through which they're looking at. And some of our lenses are like bifocals, right? Some of us are blind and we don't even know it.
Yes.
We're blind and we don't even know it. And so that can be blindness that comes from a lack of understanding of different cultures, but it also can be self-focused. And so sometimes when you're having a difficult time, even yourself at home, you get so self-focused that disables your ability to care in the best way that you can care. And so funny enough, Rachel said, sometimes you're just doing your best, but I'm calling, I can't say what I want to call it, but for some of us, we say that we're doing our best, but we're not. Okay, so I'm going to call you out if you're not doing your best, and you're going to go ahead and call yourself out. But if it's not you, I'm not talking to you. But if it is, I'm talking to you. And so we need to step back and kind of evaluate, what are the processes that are existing, and how do we need to kind of adjust some of our processes so that we can actually do our best. So some of us aren't doing our best because we haven't taken the time to think about how to readjust and to do things differently, and not do things differently because we're doing stuff messed up, because that's different, right? But do things differently because we're rethinking about how the rules and regulations affect our day-to-day life and how we can manage, and how we need to make some adjustments to that so that we can then keep our cups as full as possible, so that we can be the best that we can be, not only for our families, but for the families that we have to care for on a regular basis, on a day-to-day basis. So, those are things to think about. And then also thinking about these at-risk populations and how now, one of the terms we use in sociology is intersectionality, and that term can be used to explain and describe people of different backgrounds and how you kind of have compounded or a newfound development of who you are in a particular space. And so these groups of people are experiencing trauma in ways that they never imagined it before, but it's very different from the trauma that they may not have been able to handle before. And so us emotionally now intelligent, or more emotionally intelligent than we were, or as emotionally intelligent, but ready to act characters that we are right now in this play that we're living in, this real world, we're going to be thinking critically about how that is real, how it is very real. And that how, sometimes we may be just thinking about the process or the rules. We may be thinking quantitatively and not, in effect, thinking qualitatively and quantitatively about those experiences, how they're heightened, and how we're going to think through this differently and be flexible and fair. Be flexible and fair. And safe space. A safe space is a space where you care. A safe space is a space where you're listening. A safe space is a space where somebody else is allowed to be present and to be special and important and valuable and real. That can be in your living room. It can be the lady saying, call me, to Elizabeth. It doesn't have to be a particular location. A safe space is a space that is respectful, a civil space.
Yeah.
So long story short, we got to go. Thank you so
Thank you so much. Thank you.
I will email everybody the information for for tomorrow and carrying on whatever registration link that we'll make sure is going and we love y'all and we're so grateful for you for attending. Thank you so very much. And
Thank
yes,
you.
and
so
just
much.
have a wonderful night. Get some rest, everybody. We'll see you tomorrow, hopefully, or we'll see you Thursday, or I'll see you when I see you. We'll have videos. All right. If you're
Okay.
registered for this
All right.
class, you need to talk to me, send me an email. All right. Bye, everybody. If you're a speaker,
Okay,
don't
bye,
you click off
everyone.
here. Don't you leave.
Bye.
Don't click off. Rachel,
Bye.
don't go. Elizabeth, don't go.
I'm staying
You
out
know,
here.
I'm like,
Everybody got to go but you. You can't go. Please,
adios, amigos.
bye, everybody. We say everybody but the speakers don't leave. All right. You all get some rest.
Yeah.
We're gonna, yeah. All right, we're gonna wait for people to.
That was
navigate.
wonderful. This was wonderful.
It was good.
It was just, yeah, no, it just like this hearing different